This is the second part of the advance directive. So first you have to choose, but then after you choose, what kind of care do you want to dictate to that person or suggest to that person that you want? You have to have a conversation with that person. And so there's several choices here. And I like this new term, allow natural death, not CPR or not no CPR. I never liked DNR, do not resuscitate, those terms, because it felt like I was withholding something and I couldn't always tell what is resuscitation or could cardiopulmonary resuscitation work. I'd rather those decisions have been made from a clinical perspective. So this is a situation I found you don't want to be the person that they're talking about in this memo here at this conference, but that's in fact what's happening every hour and every day in every hospital in the United States. Someone comes in, there's a person in trouble, and we're all trying to figure out what action to take. Who do we call? And when someone comes in, we start making phone calls, and you may get that call, grandma, grandpa's in the emergency room, or maybe a young person. You never know. So you have to make some of these decisions, and they're tough decisions, and you need to think them through, but they're not that hard when you go through the forms. So let's look at this. There's the full court press. You get everything. And there's times when this is appropriate. If you're a young person, you don't have any other problems, yeah, you ought to be going for pretty much a recovery. There are clinical conditions like people who have drownings in cold water where there's a real good chance of resuscitation. That's different. It's a lot different than the other end of the spectrum. Just to paint the picture, a 99-year-old nursing home patient who's been diagnosed with serious dementia for the last 10 years, is in diapers, and all their hygiene issues are managed for them. It may not be appropriate to have this as the decision for that. But again, in that situation, it's up to you. Then on the other end of the spectrum is this, and that may be exactly where you want to go. Let me say a couple of words about hospice and palliative care. The thing I hear about, the most common comment I hear about hospice care is, I wish I'd called hospice sooner. You're entitled to 6 months of hospice care. It's covered by Medicare. The average length of stay in the United States is 2 weeks. So we're just not getting to people sooner. Think of it this way. You've bought 6 months of it and you're only using 2 weeks. Think if that was a vacation home, that would be wasteful. Call hospice early when you're well. Don't wait till the end, or at least at the beginning of any serious illness. And let me say about palliative care, which is supportive care, not always end of life. There's a famous study in the New England Journal of Medicine. They took 2 groups of people with identical lung cancers. Half got early palliative care, the other did not, but they got identical treatments. So the only difference was palliative care. And clinicians, unfortunately, too often have had the idea, well, we don't know what to do with this patient anymore, so let's call palliative care in, the palliative care specialists. They come in late. But when they came in early, here's what happened. The people who got early palliative care, remember, these people got identical treatments. Early palliative care, lived longer, had a better quality of life, spent less money. That's a pretty good trifecta. Lived longer, better quality of life, and spent less money. So get involved in these things early. Very hard to make medical decisions anyways. So the more you get out of the way in advance, that's what to do. The middle path, well, you sort of have one extreme and the other. There's always the middle path. And this is what mine says. And you can put additional things in your advance directive. Obviously, mine says if I'm going pretty well, keep me going. But if no extraordinary care, something comes up. But mine, you can put other things in your advance directive. For example, mine says I want control of the remote. Mine says take me outdoors as much as possible. And if I can't be outdoors, at least put me near a window where I can look at the outdoors. Mine says I'd like a bite of chocolate every day. You can also actually control some of your visitors. You can say, these are people I'd really like to see me. But maybe you have an annoying relative in your family that takes over conversations and runs their mouth. You could say, please don't let that person around when you're making medical decisions about me, or I don't want them in to visit me. You can actually do those things. And so you can put more and more stuff in your advance directive than you might imagine.